Hi everyone, I am Dr. Sagar Sahu and welcome to Teach. So today I welcome you to another lecture in the radiography pathology of thorax. We have already completed the radiography pathology of the abdomen. Okay, so I will give the link in the description to the playlist radiology. You can check all the videos that has been uploaded before this video. Okay, before in thoracic pathology I have also covered the larynx and trachea. You need to watch that also. There's some part of the larynx and trachea applies to the esophagus also. Today we will be discussing the esophagus. So this is the book which I am referring, Veterinary Diagnostic Radiology by Donald D. Throth. This is a very good book. If you are no knowledge beyond this class also, you can refer this book and take notes from this book. Okay, this is a very good book. Coming to our class, the radiograph of the esophagus can be done in three ways. First one is the survey radiograph. You know this only without anything. Simply take a radiograph, survey radiograph. Next is static contrast radiograph. This is basically done to confirm some diseases which are found in survey radiograph, or in survey radiograph you may not appreciate some diseases. By contrast you can confirm them, like esophageal mass, non-radiopaque foreign body. Radiopaque foreign bodies are easy to diagnose but not the non-radiopaque foreign body. Esophageal stricture, we will discuss all these diseases also. Okay, so you can tell that this is the index, okay, which we will be studying. Vascular ring anomaly, esophageal perforation, esophageal diverticulum, hiatal disease. Part of the hiatal disease I have already covered in the stomach section. Okay, so I will give the link to the radiographic pathology of stomach. You can check that out because I will be skipping some part. Next is dynamic contrast radiograph. This particular technique is used to diagnose dysphagia. Dysphagia means irregularity in swallowing or difficulty in swallowing or some abnormality in swallowing. Okay, for that you need fluoroscopy. Okay, we will discuss also, we will see the images also. Next we will go for the normal anatomy. Anatomy by things you can find in radiograph. First thing you should notice is cricopharyngeal sphincter. It is also called as anterior or cranial esophageal sphincter. You will also find the esophagus because we are doing the survey radiograph. Esophagus is divided into two portions, the cervical portion and the thoracic portion. The cervical portion and the thoracic portion. Also we will find the longitudinal folds. These folds are appreciable in contrast radiography. Longitudinal folds. Okay, longitudinal folds. Let us go to the radiograph. This is the first radiograph. Here you can see this is esophagus. Esophagus is only visible because the air is present. Okay, below that this is trachea. See, here is the epiglottis. This is oropharynx, this is nasopharynx. So when food will leave the oropharynx and enter the common pharynx, it will go like this to the esophagus. So before going to the esophagus, here can you see this particular structure here? Okay, it looks like some sphincter. Okay, this is cricopharyngeal sphincter. Below this, here is the cricoid bone, cricoid cartilage. There are three cartilages: arytenoid, thyroid and cricoid. Cricoid is triangular shape cartilage. So above this there will be cricoid sphincter. We will see some fluoroscopic image also. There you can clearly see how the sphincter looks. Normally they are of soft tissue opacity. If there would not have been any air, then you cannot appreciate this sphincter. Okay, sometimes they are visible. Next, the part, see, this is cervical esophagus. The above one, this one is esophagus. The esophagus is only visible because the air is present, or animal has swollen some air like aerophagia. In that case, you can find or appreciate the esophagus. Here, can you see this one? This is the thoracic esophagus. Because of air present, you can appreciate the esophagus. And this particular band sign is known as tracheal stripe sign. We will discuss, okay, what is tracheal stripe sign. So this is basically to show the folds, longitudinal folds. Can you see some longitudinal folds like this here? Okay, these are longitudinal folds. So longitudinal folds is why these folds, longitudinal folds. So these folds is because of the muscular layer. So these muscular layer contains striated muscles, which is arranged in longitudinal fashion. But in case of cat, especially in case of cat, the caudal 1/3 of esophagus, it contains smooth muscles. Which is arranged in oblique fashion. Rather than longitudinal, they are arranged in oblique fashion. Due to this, when you will do the contrast imaging of esophagus of cat, in the distal third, you will find a striated pattern. Unlike dog, striated pattern. Here see the fold, how they are longitudinally arranged, but see here, it is striated pattern. This particular pattern has some other name also, which is herringbone pattern. Someone might ask you question, herringbone pattern. It is found in case of cat, okay, because it contains smooth muscles which are arranged in oblique fashion, especially caudal 1/3 of esophagus. So these are folds. Folds are appreciated when the contrast esophagogram is used. Next, some normal radiographic finds, normal survey radiograph. Usually the esophagus is not visible in normal survey radiograph unless and until air is present. Okay, but in case if you are doing left lateral radiograph, then especially the caudal thoracic portion of esophagus will have a fluid opacity. So this fluid opacity on the background of air opacity can be visible. Now my question is to you that why in left lateral the esophagus is visible? Okay, the hint is it is dependent on the fluid and gas distribution in stomach. Okay, I have already discussed in stomach. You can comment the answer or you can watch that video then answer. Okay, so here in this particular case, can you find the esophagus? This is esophagus. Another landmark is the caudal, especially this caudal thoracic esophagus, that it is found, or the position of this caudal esophagus is between the aorta and caudal vena cava. Can you see here? This is esophagus, this is caudal vena cava. Can you tell how can you tell that this particular radiograph is left lateral? I have discussed this so many times. Okay, if you are following the radiography pathology sections, I have discussed so many times. Okay, can you see the diaphragm? It is verging out. Okay, and also see the caudal vena cava. It has crossed the left crura and joined to the right crura. Okay, and also between the abdominal aorta. It is not differentiated pattern, only the location of esophagus. This is esophagus. Okay, this is caudal vena cava and this is aorta. This particular position is very important. Okay, many of the pathology of the esophagus we will find in particular this portion. Many of the radiographs we will see, many of the pathology will be in this portion. So we have to fix in our mind that in which position the caudal 1/3 esophagus is present. Most of the pathology you will find there. So in between the caudal vena cava and the aorta. Here you see, this is the tracheal stripe sign. See, this is tracheal stripe sign. This is trachea, and which is ending in this conical structure known as carina. So when the esophagus will be containing gas, esophagus lies just above the trachea. So when it will be containing gas, can you see here? This is esophagus. Okay, so the ventral border of esophagus and the dorsal border of the trachea will appear like a band. They will merge together and will appear like a band. See this, appear like a band. It seems like that this is a particular chamber and here is a band. Okay, so this is known as tracheal stripe sign. Also it can be called, or it is known as esophageal stripe sign. Okay, so this sign indicates. This sign is particularly found in 3 cases. First one, when there will be general anesthesia or the animal is under general anesthesia, you will find the esophageal dilation. This is a sign of esophageal dilation, but there are some conditions. Second, when there will be aerophagia, especially when the animal will be brought to your clinic, they get stressed and they engulf air or the shallow air. So in that particular case also you will find tracheal stripe sign. Third one is a pathological one. These two are normal one. Okay, these two are normal cases. Pathological one is megaesophagus. Esophagus. Okay, so in this case also you will find tracheal sign. We will discuss megaesophagus in detail. Okay, you don't need to worry. So this is basically tracheal stripe sign, which you can find in normal survey radiograph as well as some pathological survey radiograph, especially megaesophagus. Next is redundant esophagus. It means esophagus is bent or kinked. It is bent or kinked. Okay, so it is particularly found in young animals. It is not a pathological one. Okay, it is particularly found in young animals, especially puppies and kittens. Okay, so this is redundant esophagus, where you will find a kink. Okay, esophagus you will find a kink or bending. Does not indicate any pathology, particularly young animals. When they will grow up, no more pathology. So next we will do the contrast radiography. I have taken a screenshot. You can take a screenshot of this one also, or you can refer the book, because describing the procedure is slightly lengthy and also it is not that applicable in video. It is much more of theory than concept. Okay, so you can give barium, it can give as suspension or a paste or kibbles or like solid food, or you can do the iodinated contrast. Iodinated contrast is particularly indicated in case of perforation. And how to know perforation we will discuss. Okay, we will discuss the esophageal perforation also. These are the techniques through which you can do the esophagram. There are 3 techniques: the static barium esophagram, the static barium meal esophagram. Here you will use the suspension and paste like thing. Here you will use the kibbles. Okay, food impregnated with barium. And the third one is static iodinated esophagram. You can take a screenshot, or you can refer the book. Okay, regarding the procedure. Next we will straight go to the pathologies. The first one is dysphagia. I told you for dysphagia we need a contrast fluoroscopy or dynamic esophageal radiography. Okay, that is contrast fluoroscopy. Here you will be measuring the onset of swallowing, that is the closure of epiglottis, to the opening of the cricopharyngeal sphincter. We will see some radiograph, then you can appreciate. So the normal value is, for liquid diet, it is 0.09 plus minus 0.02 second. It means 1/10 of a second. It's too fast. Okay, so for this is too fast, so you need at least 30 to 60 frame per second. 30 to 60 frame per second. Okay, for any video you know that it is frame per second. Okay, so many of the fluoroscope machines have 6 to 8 frames per second. They are not ideal. You cannot find this 1/10 of a second. Okay, so you need 30 to 60 frame per second machine, fluoroscopy machine. So the normal value is for liquid 0.09 plus minus 0.2, for kibble or solid diet 0.10 plus minus 0.3 second. What is the delayed or having this, when the animal will having dysphagia, then the liquid diet, for the liquid diet you will get 0.31 plus minus 0.1 per second, kibble 0.37 plus minus 0.06 second. Okay, these are the values. You can write it down. Okay, don't need to remember. When the problem will come, you will simply look at the values. You don't need to remember or mug up everything. Dysphagia in cats is less commonly reported than the dogs. Okay, let us see some images. These are the frames obtained from the fluoroscopy. Okay, in fluoroscopy, in radiography, which looks white, in fluoroscopy will look black. Okay, so vice versa. Okay, So here first one you see this one. First this one is one, first frame, second frame, this is third frame. So in first frame, can you see this black thing? Okay, this is a bolus. Another bolus has passed this cricopharyngeal sphincter. Can you see this sphincter? Okay, this is cricopharyngeal sphincter. This particular portion is cricopharyngeal sphincter. Here is a bolus. Another bolus has passed. The black one, the contrast agent. Now the cricopharyngeal has been opened and the bolus inside the pharynx or oropharynx or common pharynx is entering into the esophagus through the cricopharyngeal sphincter. Next, in third phase, the bolus has already entered in the esophagus. Okay, this is the complete bolus. So this you have to evaluate it in fluoroscopy machine. You have to obtain a video, then you have to go for frame by frame, and you have to identify that how much time from this closure of the epiglottis to opening of the cricopharyngeal sphincter. Okay, before that you should know some things like the swallowing has different phases. First phase is known as oral phase. Second phase is known as the pharyngeal phase. The third phase is known as cricopharyngeal phase. Fourth one is known as esophageal phase, and the last one is the gastroesophageal phase. The names are self-explanatory. Okay, gastroesophageal phase. The most important for where dysphagia you will find most commonly in these three phases: oral phase, pharyngeal phase, and cricopharyngeal. Here this is actually oral phase. Okay, it is present in, this is pharyngeal phase. This picture is of pharyngeal phase. This picture is of cricopharyngeal phase. Cricopharyngeal phase. And this phase you can say clearly that is esophageal phase. Okay, now you understood that dysphagia, okay, the phases and how they are evaluated. You have a fluoroscopy machine in your department, you can do this. Next disease is the megaesophagus. Before going to megaesophagus, there is a generalized disease which is known as the esophageal dilatation. Under this, broadly two diseases are there. Dilatation. One is megaesophagus, other is hiatal diseases. Okay, so esophageal dilatation can be divided into segmental or generalized. So in case of segmental means it might be cervical or it might be thoracic. In case of generalized means whole esophagus is dilated. In case of generalized, usually the thoracic portion you will find the dilation in thoracic portion. Why? Comparative to cervical portion. Why? Because inside thorax there is negative pressure. Okay, because of negative pressure inside the thorax. Okay, so most of the dilatation of esophagus you will find inside the thorax. Also, this esophageal dilation can be classified into mechanical or functional. Mechanical means there might be some kind of obstruction, mostly obstruction. Okay, obstruction or inflammation. In case of functional, where the nervous system is affected, neuromuscular problem. Okay, so this is generalized term esophageal dilatation. We will study megaesophagus and the hiatal diseases. So this is megaesophagus. What is megaesophagus? Megaesophagus is dilated and hypomotile esophagus. Dilated and hypomotile esophagus. Okay, so in case of megaesophagus you have to find some signs. Okay, then in lateral radiograph, first I will tell some theory, then we'll look at the radiographs. Okay, so in lateral area you have to find 6 signs: 1, 2, 3, 4, 5 and 6. You may not find the combination of all 6, but you may find most of them. First one is obviously it is dilatation. It is dilatation. Second, you will find soft tissue bands. Soft tissue bands. Okay, these bands actually define the walls. Bands. It might be dorsal or ventral. Okay, mostly the dorsal and ventral. Dorsal band and ventral band. Okay, third you will find tracheal stripe sign. Tracheal stripe sign. Okay, next you will find the border of longus colli muscle. Longus colli muscle. Fifth one, you may find the azygous vein indentation. Azygous vein indentation. The last one, you may find the ventral deviation. Ventral deviation of trachea, sometimes trachea and or heart. In severe dilatation it may also deviate heart. So these are the 6 signs you may find in case of megaesophagus. Okay, in lateral. So what will you find in VD? VD nothing much, you will find some bands. Due to superimposition of the vertebral column you may find bands. Sometimes in not so severe or mild dilatation you may find one band which is basically on left side, left to the midline. In severe dilatation you will find two bands that will converge. We'll see all these in radiographs. Okay, don't need to worry, simply listen and see. Two bands which will converge towards diaphragm. Okay, so you have noted down the things which you will find. Let us find those things. Megaesophagus. Megaesophagus, one other thing, megaesophagus is very less reported in case of cats. Okay, it is more commonly found in case of dogs. So let us see this radiograph. So here can you see the dorsal wall of the esophagus? This is the esophagus. This is the ventral border. One sign. Can you see the tracheal stripe sign? This is tracheal stripe sign. The dorsal border, can you see? This is the ventral margin of the vertebrates. Okay, can you see this soft tissue? This soft tissue. This is longus colli muscle. Okay, this dorsal wall will touch the longus colli muscle, and the normally longus colli muscle is not that visible. Okay, because of the lungs present. But when the air is present inside the esophagus, due to megaesophagus, the radio opacity is increased and the muscle is now clearly visible. So this is longus colli muscle. Can you see this indentation at the level of carina? This indentation, it is not always visible, but sometimes they are visible. This is indentation. due to azygous vein. Azygous vein. Okay, so these are the symptoms. Megaesophagus. Let us go to this one. Let us see what we can find. We can find the, this is, here is the ventral border, here is the dorsal border, here the indentation is not that clear. Also we can find the tracheal stripe sign. Okay. Okay. Another thing, can you here find the, sorry, can you here find the, this is the caudal vena cava. Here the aorta is not that visible. Okay, here also you can find the caudal vena cava here. Okay, the I told you the thoracic portion is between the aorta and the caudal vena cava. Next, let us see here this image. Can you see? You can see signs like deviation of the trachea, ventral deviation of the trachea. You can clearly see it is dilated. Okay, the esophagus has been dilated. Here is one border and another border is here. Okay, here. This is VT view. Can you see the two borders? Here is one border, here is another border. I told you they will go converge towards the diaphragm. Okay, so these are the signs of megaesophagus. We can also do the contrast radiography for confirmation. Next, hiatal diseases. So the hiatal diseases, mostly the diseases which is associated with esophageal hiatus. Okay, it can be hernia, it can be hernia, or it can be gastroesophageal intussusception. Okay, also it can be GERD, gastroesophageal reflux disease, GERD. So the hernia is also different types. I have discussed vividly in the radiography pathology of stomach. Just I am giving some hints so that you can appreciate the radiographs. So hernia is basically three types, hiatal hernias. First one is the sliding esophageal, sliding hernia, sliding esophageal hernia. In this particular type, both the esophagus and the fundus of the stomach will be herniated into the thorax through the esophageal hiatus. Second type is the paraesophageal, in which the esophagus in normal position, only the fundus will be herniated to the esophageal hiatus. Third one is the mixture of these two. Okay, mixture of these two. Basically the esophageal, the hiatal disease consists of all this. GERD is very difficult to diagnose in radiographically, but these things you can diagnose radiographically. Let us see some radiographs. Can you see here? This is the stomach actually. You can see this fundus is herniating into the thorax. Can you see another thing here? If you have noticed, can you see the sternum is slightly inside or bent towards, the overall chest capacity is lowered. Why? You don't know actually, because this particular dog, the radiographer particular this dog was having upper airway obstruction. When there will be difficulty in respiration, animal will try to forcefully breathe. Okay, for that the chest capacity has been reduced. And another thing, when there will be hiatal hernia, especially the sliding hernia, you may not get this radio opacity. Okay, in every radiograph. It will only be present when the abdominal pressure will be increased. Sometimes you have to compress the belly so that abdominal pressure will be increased and the stomach will get herniated. Okay, and the typically this herniation will be at the dorsocaudal margin of thorax, dorsocaudal thorax. Okay, dorsocaudal thorax, this particular region. Let us see here also. Can you see here? It is clearly showing that the gastric thing has been herniated. Here is the caudal vena cava. Okay, here is the aorta is going. Okay, this particular region. Some part has also come here. Okay, there might be some things. I will see the video radiograph so that you can appreciate. Here you see the VD radiograph. Can you see the VD radiograph? You see this one has been herniated. Can you find the esophagus here? Esophagus has been dilated. Can you see this esophagus? I am drawing. Appreciate this one. Okay, this is the esophagus which has been dilated, and the fundus of the stomach has been herniated through the esophageal hiatus. Due to this also you will find the dilatation of the esophagus. Here you see this is actually gastroesophageal intussusception. Gastroesophageal intussusception. Okay, the typical feature of intussusception is in air background you will find a convex bulge. Okay, here this is tracheal stripe sign. Okay, no doubt regarding that. Can you see this is esophagus? This is esophagus. Can you see this convex bulge? Okay, this is gastroesophageal intussusception. Okay, they come under also hiatal diseases. Okay, these are very rare diseases. If you are finding, then you may own a gold medal. Next, pathology is a foreign body. Foreign body can be of two types. One is radio opaque, which include metal opacity or bone opacity. Okay, they are very easy to diagnose. Another is non-radio opaque. Okay, for this you need contrast study for confirmation. Here you see a bone piece has been lost, though it is not inside the esophagus, just at the cricopharyngeal sphincter. Okay, here also can see the large bone has been lost. Okay, this has a sharp edge. This large bone has been lost in the thoracic esophagus. Let us see another images. Here is safety pin. This is safety pin which has been lost in the cervical esophagus. In this particular case, can you find some radio opaque thing? It is a bone piece which has been lost in the caudal thoracic esophagus. There are some common locations. You should know that common locations where these obstructions can be found. Common locations like thoracic inlet, next just cranial to heart base, and at the level of diaphragm, just cranial to diaphragm, or you can say cranial to the esophageal hiatus. Cranial to diaphragm. Okay, so basically at the level of thoracic inlet, at the level of heart base, and at this level, that is the cranial to the diaphragm. These are the common sites, because at this site esophagus cannot extend much. Okay, that is why the obstruction happens there. Next, these are some images, same images. Here actually it is non-radio opaque foreign body. Here can you see a foreign body here? Okay, in the ventrodorsal you can see here. Okay, you can confirm this particular non-radio opaque foreign bodies by contrast radiography. Okay, here let us see some other things. Here is aorta. Okay, here is vena cava, caudal vena cava. I'm sorry. Here is the caudal vena cava. Okay, the caudal vena, between this there is esophagus. Okay, and one more thing, let me clarify here. If you are finding any mass here, it can be of three things. First, it can be of pulmonary mass. It also can be mediastinal mass. It can also be esophageal mass. So how to differentiate them? Esophageal, especially in lateral view. When you go to the DB view, Now the long part is over, pulmonary passage is gone, only there are two suspects, mediastinal and esophageal. Okay, so for this you need contrast will definitely clarify the esophageal one or confirm the diagnosis. Okay, this particular position you may not find any mediastinal problems, only the thing mediastinal lymph node, which is here you can see the trachea actually. Okay, here you will find the mediastinal lymph node. Okay, so in this particular position you may not find any mediastinal things, but to clarify you can go for contrast for esophageal things. Okay, next the vascular ring anomaly. So the vascular ring anomaly actually mainly it is of congenital origin. It is mostly found in young animals as it is congenital. Mostly clinical symptoms you will find in young animals. If you will see the categorization of vascular ring anomaly, it is category 1 to category 7. Okay, 7 types, but mostly you will find 2 frequent types, that is PRAA, ARSA. What is this? This is persistent right aortic arch, and this is aberrant right subclavian artery. Okay, these are the diagram. This diagram is also in the notes. I will provide the notes also. So for your understanding I have made this diagram so that you can understand better. So this is basically VD view. Okay, how you can see in radiograph, VD view, all those VD view. So in normal case, when animal is everything is normal, you will see that this is esophagus, the blue line, green line is pulmonary artery, the red one is the aorta. Okay, in normal cases this is left side, this is right side. So the pulmonary artery and the aorta, both these two structures appear to be left of the esophagus. Okay, but in case of PRA or persistent right aortic arch, what happens? This aorta, instead of being on left, it is on the right. Another thing, this artery is left subclavian artery. Left subclavian artery originates from the aorta, while the right subclavian artery originates from the brachiocephalic trunk. We will see some other images also. Okay, so between this aorta and pulmonary artery there is a band. Okay, in fetal time it is vessel, but with time it gets fibrosed. Okay, as a ligament, this ligament is ligamentum arteriosum. Okay, so in case of PRA, when the aorta is on right side, you see this ligament will be there. Okay, so what will happen? This ligament will be just above the esophagus. Okay, so between these two structures, esophagus will be there, and in dorsal side you will find this band, and the ventral side there will be heart. We will see also images also. So due to this, they will compress the esophagus. Okay, now we understood the PRA, what is the pathology. We will also see other images also. Now to aberrant right subclavian artery. But in this case, the aorta and pulmonary artery, they both are in the normal side. But the right subclavian artery, which should originate from brachiocephalic trunk, instead of originating from the brachiocephalic trunk, it appears or originates from the aorta. In that particular case, this left subclavian artery will go to the left limb, supply to the left limb. The right subclavian artery will go to the supply to the right limb. This crossing over the esophagus will cause the constriction of esophagus. It is mild form of this one. In this particular case, the esophagus will be severely compressed because there is solid organ below, heart. While in this particular case, it is very mild form of this one. We will see the radiograph also. Okay, let us see some other images so that you can clarify. This is better image, obviously, but you need a 3D view. Okay, from dorsoventral, this is from lateral view. You see the right aortic arch. Okay, the aortic arch should be on the left side, but instead it has crossed and gone to right hand side. This is ligamentum arteriosum here. Okay, can you see how it is compressing the esophagus? Okay, from the aortic arch, the left subclavian artery originates. Okay, so now you can, from this picture, PA is pulmonary artery, CBC is caudal vena cava, L8 is left atrium. Okay, now we can see how the compression occurs. Similarly, this is the aberrant right subclavian artery. So here you see, usually the right subclavian artery originates from the brachiocephalic trunk and supplies to the right limb. Okay, instead of originating from brachiocephalic trunk, it originates from the, here the aortic arch in normal side, left hand side. Okay, here is left side, into the white smart board is the right side. So instead of opening there from the brachiocephalic trunk, originating from brachiocephalic trunk, it is originating from the aortic arch. Okay, so that is why it is causing the compression. Here the compression is severe, here the compression is slightly mild, because below that there is no solid structure, but here just below this compression there is a solid structure, that is the heart. That is why the compression is much severe. And another thing, the location of this compression here is just at the base of the heart, while it is much more cranial. Okay, it is much more cranial to the heart. We will see in the radiograph also, there you can appreciate. Now you have understood the concept behind the pra and aberrant left subclavian artery. So here is the image. You can see here the esophagus is dilated just cranial to the base of the heart. Here is the esophagus. Okay, another thing I forgot to mention. So in this particular case of pra, in this pra case, what will happen, just below the esophagus there will be trachea. Due to the pressure of this one, the trachea might get bent towards the left side. Okay, this is a bending of the trachea towards the left side. This is also a characteristic sign of pra. Okay, radiographically you can find. Okay, so here coming back to our radiograph, here is the esophagus which is dilated just cranial or just at the level of heart. This is heart. Okay, heart, at the level of heart it has been dilated. So most probably this is a case of persistent right aortic arch. This is a dorsoventral radiograph. You can see the trachea is slightly bent. This is trachea which is slightly bent, okay, towards the left hand side. This is the characteristics of pra. You can also go for contrast. We'll see some contrast images also. You can nicely diagnose this disease. Here you can see this is heart. This is heart. At the base of the heart, you can see the kinking of the trachea. This bending or ventral displacement of the trachea is due to some dilatation, mostly the esophageal dilatation. Okay. Here you can see the dorsoventral. Here you can see, only appreciate that the mediastinum has thickened. Okay, mediastinum has thickened. It is only because of the esophageal dilatation. Next we will see the contrast image. You can see this contrast image, very nicely seen. Sorry, this is contrast image of persistent right aortic arch. Can you see, this is heart. Okay, at the level of base you can see that it is tapering. This tapering. Okay, this is esophageal dilatation and it is tapering. Now you can see clearly that this is persistent right aortic arch. Characteristics, that at the base of the heart there will be stricture or the compression. Next is the aberrant right subclavian artery, aberrant right subclavian artery, ARSA. Okay, so in case of ARSA, it is slightly cranial to the base of the heart. Actually the base of the heart is not that clear, might be some pleural effusion. So it is slightly cranial and it is not that severe, like in that case you have seen how much of dilation in case of pra, but here it is not that much of dilation, only a stricture is there. Okay, so this is less severe than the pra, persistent right aortic arch. So these are basically the vascular ring anomalies. Now the strictures. So the strictures means narrowing. Any strictures means narrowing. So the stricture can be mechanical or it can be functional. Okay, mechanical means some problem, obstruction, or the functional means mostly neuromuscular. Another classification of stricture is, this is not stricture, this is diverticulum. The strictures is mechanical functional. Radiographically, what you can find, radiographically, mostly when there will be stricture, you will find a dilatation behind that, or cranial to the dilatation, cranial to the stricture. And second, you will find tapering of the esophagus, tapering. Okay, it is best visualized in contrast radiograph, like this radiograph. Okay, like this radiograph. See here, can you see? Here is stricture, it is going up, and here is the stricture. Okay, so this is the dorsoventral view, you can see, and here is the stricture. Okay, so this is basically the stricture of the esophagus. This is another image of the, and one more thing regarding stricture, you might have heard about the Spirocerca lupi. Spirocerca lupi. This is a parasite, Spirocerca lupi. This is a parasite which can cause masses or tumors of esophagus, especially in case of pet animals. The tumor of esophagus. Okay, so when they cause tumor of the esophagus, mostly the most common location is the between the aorta and caudal vena cava, that is the caudal thoracic esophagus, caudal thoracic esophagus. Here in this particular radiograph, you can see this is the caudal vena cava. Can you tell this is left lateral or right lateral? So this is left lateral, it is crossing one crura and joining to other crura, and here is the abdominal aorta. Okay, between this, can you see a swelling here or mass here? Okay, so this is basically the mass of esophagus. You can confirm it. I told you it can be pulmonary, it can be mediastinal, it can be esophageal. So when you will take a VD view, here is some swelling. Okay, sometimes it gets superimposed to the spine, you may not appreciate, but it will definitely rule out the pulmonary one. Okay, pulmonary one. So after that it goes up to the mediastinal and the esophageal. You can do the contrast to know whether it is mediastinal or esophageal. Another thing, you can do the endoscopy also. Endoscopy is better choice for esophageal things. In many of the diseases can easily be diagnosed by endoscopy. Here a CT image was actually taken. You can see the computed tomography. This is actually esophagus. Okay, in the, this is left side, this is right side. In the left wall there is a tumor mass. Okay, mostly it is Spirocerca lupi. Okay, in case of dog and cat. This is another image of tumor. Here you can see the caudal vena cava. This is caudal vena cava. Here it goes the aorta. So you can see here a mass. Okay, now this is VT view. We can see here the mass. Can you see two nodules here? This is inside the lungs. Here it is nodules. Most probably that tumor has metastasized into the lungs. Okay, let us see another examination of mass. See here, this is another of mass of esophagus. Okay, this is here the caudal vena cava. You can see here the mass. This is the mass. This is the VD view. And one more thing, can you identify one mass here or nodule here, one nodule here, and another nodule here? This is lungs nodule. This is most probably metastasized. Okay, so here it is the mass. This is the mass. Okay, esophageal mass. It can be esophageal and mediastinal. Okay, you have to go for endoscopy or contrast agent or CT if you have to further diagnose. Okay, most probably in this particular place you may find esophageal masses. Okay, or also it can be mediastinal lymph node enlargement. So you have to go for further diagnostic things. but it can give you idea. When there will be some esophageal problem, the clinical sign you have to relate to the clinical sign. The clinical signs will be of esophageal origin. Okay, if some mediastinal mass, then it might have some different symptoms. Okay, but in that also you can diagnose. If it has been pulmonary problem, then there might be respiratory signs. Okay, so all those things you have to correlate, and also you have to go for the tests. Okay, next is diverticulum. Diverticulum is of two types. Diverticulum means some pouch formation, pouch. Okay, it is of two types: pulsion type diverticulum, and the traction type diverticulum. What is pulsion type diverticulum? So the pulsion type diverticulum means when there is increased intraluminal pressure of esophagus. Okay, when this happens, when there is foreign body, if there is some foreign body, or there is some chronic esophageal disease, okay, chronic inflammation or chronic esophagitis, like these things. What is traction? Traction diverticulum, it happens when there is adhesion of wall of esophagus to nearby structures. It might be due to something, mostly the inflammation. Okay, adhesion of the wall of the esophagus. They have a particular locations, like most commonly the pulsion type you will find at the caudal esophagus. While this traction type you will find the cranial and mid thoracic. Esophagus. Most common one is the pulsion type. Okay, you will find most commonly the pulsion type. The radiograph here displayed is of pulsion type. You can see here. Okay, you can see here. This is the dorsal border of the esophagus. Okay, here is the caudal vena cava. Here is the ventral border. If you will to the dorsoventral, you can see pouching towards the right side. This is pouching towards the right side. This is esophageal diverticulum, and you can best diagnose in contrast. When you will use contrast, the typical feature of contrast esophagram is that when you will take serial radiographs, you will find the contrast inside the pouch in serial radiographs. You will take consecutive radiographs. In all those things, you will find a pouch where the contrast image is there, contrast agent is there. That is the particularly characteristics for a diverticulum. Okay, serial radiograph. So this is diverticulum. Next, the last one is the perforation. So in case of perforation, you will find you should look for some signs, like if you are finding pneumothorax, or if you are finding pneumomediastinum, we will also discuss all those things in subsequent. When we will deal with the thoracic work, we will see the pneumothorax. When we deal with the mediastinum, we will see the pneumomediastinum. Okay, don't need to worry. Next, when we will deal with the pleura, we will see the pleural effusion. So if you are finding these three things are potential cause of perforation. Okay, so when you are finding these three things, do not go for barium shallow. Never go for barium shallow. Okay, if at all you need a contrast, you can go for the iodinated contrast. Okay, so in this particular case, you can see here the pleural effusion. This is pleural effusion. The opacity of the thorax is lost. All are having some soft tissue or fluid opacity. This is pleural effusion. Here you can see, I have already shown you this radiograph actually. So this is the bone piece. Most probably this bone piece has done some injury to esophagus. There is perforation, due to which there is pleural effusion. Okay, so in this particular case, do not go for barium study. Okay, and another thing regarding the perforation, The perforation can be cervical, in the cervical esophagus, or in case of thoracic. If the perforation is thoracic, then prognosis is graver than the cervical one, or you can say prognosis of cervical perforation is better than the thoracic one, because when there will be thoracic perforation, you may find mediastinitis, and also you can find sepsis. Okay, all those things can happen, and the prognosis becomes grave or guarded like that. Okay, so this is the last thing, the perforation. With this, we have ended the radiography pathology of the esophagus. Next, we will go for the radiography pathology of thoracic wall. So till then, tata, bye bye, take care.